Welcome, Virginia and beyond, to our Lunch and Learn series hosted by the Black Doctor Policy Hub. My name is Jade Curtis. I am the executive editor of BDO and your moderator for this discussion. This is the first in a new series where we shine a light on the broken parts of our healthcare system and begin the work to fix them. Today, we are honored to welcome voices and influencers from across Virginia as we tackle some of the most impactful and often confusing health policy issues affecting our communities and our wallets. That's 340B, PBMs, and MFN. If you're new to those acronyms, we'll break them down in just a few moments. We're going to dive into the urgent need for transparency and accountability. The 340B program, while critical, is plagued with oversight and challenges. PBMs are increasingly acting as gatekeepers, limiting access to life-saving care, and MFN policies raise tough questions about equity in pricing and access. Our conversation is sparked by the New York Times investigative reporting and other recent coverages that calls on all of us to demand better, more transparency, more accountability, and more impact. The Black Doctor Policy Hub makes complex policy issues clear and amplifies your voice. Together, we bring clarity, raise awareness, and push for real change. So without further ado, I'd like to warmly welcome our guests today, John Newby and Dr. Harry Gwantner. If we can go ahead and bring them up to the stage. Thank you all so much for joining us today.
Thank you.
Of course.
It's an honor.
Of course. So let's go ahead and dive in. I'll start with John. John, as the CEO of Bio in Virginia and a respected industry leader, we're honored to have you with us today. So if you could please introduce yourself and help us understand the local policy challenges, tied to 340B, PBMs, and MFN. And like I said, there may be some people who are unfamiliar with those acronyms. So if you could please break those down and explain how they affect people in our community.
Sure. Thanks again for having me. Again, John Newby from the Virginia Biotechnology Association. Virginia Bio is Virginia's trade association for the biotech industry. Our members are companies in the space of biotechnology and also supporters of biotechnology as well. So, Jay, you can give me a big task to describe these three things. So I'm going to try to be very efficient with my introduction to the crowd on what these things are. So I'd like to start with the 340B program. The 340B program was actually created in 1992, which just by chance is the same year Virginia Bio was founded. What it requires is for drug manufacturers to provide drugs to eligible healthcare organizations and covered entities at significantly reduced prices. Great intent. The intent there also is to help safety net hospitals and other eligible healthcare providers purchase outpatient drugs at significantly reduced prices, and then take the delta and those savings and apply it to providing expanded and enhanced services for underserved communities. When done right, what is the effect? Lower drug prices for those in need and greater services provided that are paid for by cost savings. That's how it's supposed to work. Mm-hmm. So let me describe next the most favored nation concept. Switching gears a bit, this is in the news recently, actually, at the federal level. And the concept here is that the United States should pay the best price for drugs due to its status as a most favored nation amongst its trading partners. What it essentially boils down to is desire for the U.S. to pay the lowest possible price that a certain number of other developed countries pay. Now, technical terms, these are countries in the OECD, the Organization for Economic Cooperation and Development, and even more specifically, the countries in that group, there are 38 of them. Only those countries whose GDP is at least 60% of America's GDP are counted when you're looking at what's the lowest price affected. So here's how it affects us. Back to your question, Jay, why does it matter to us? At the end of the day, MFN is not a good solution to what is a real problem. We all admit that our healthcare system is much higher in price than others across the globe. But we don't think this is a way to positively affect that. As a matter of fact, here's the effect. Here's the irony. An MFN policy will actually reduce the number of available drugs in America in several ways. One, for those innovator drugs that are out there, you're reducing an incentive for them to create and invest in new drugs. If you're forcing the price down to match price is ex-US, then an investor will look at that and say, why am I going to put my money into that space? A company will look at that and say, why we're going to invest in that space when we cannot get a significant return on our investment. And so we're just not even going to bring a drug to bear. That's a possibility. Or we're going to reduce the supply of a drug. The other thing is, if you look from the generic perspective, generics outside the U.S., they lose their price distinction against the innovator drugs, which means in shorter terms that a generic will look at a most favored nation arrangement and say, I can't compete against what is now a lower U.S. price as a generic, because my advantage before was I was lower than them already. And if the price comes close to where I am as a generic, it doesn't make business sense for me to continue and provide drugs. So both of those things combined, ironically, if the most favored nation policy is put in place, will actually literally reduce the amount of drugs that are available here in the U.S. As a matter of fact, CMS itself indicated that an MFN can lead to a 20% reduction in new drugs. Finally, PBMs, very quickly, so I can hand it over to Harry for his conversation. A PBM is essentially a middleman in between you and your drugs. Long story short, there's a lot more explanation behind that, but essentially, they're the folks who work to create formularies that list preferred drugs with different prices and cost sharing arrangements between insurers and pharmacies and manufacturers. At the end of the day, they act as middlemen, and they take some of the savings that should result from this arrangement and peel some of it off to themselves. And also the other perverse thing is they're given how the system is set up, the PBMs are paid based off of a percentage of the list price of a drug. So they're incentivized to, on the formulary, look to drugs that cost even more. Mm-hmm. They can line their pocket even more. So long story short, those three items are what we're talking about here, and they have negative implications. But for 340P, there's a positive implication if we do it right.
Gotcha. So thank you so much for kicking us off and sharing that insight. And Dr. Harry, are you ready to dive in? I have some questions for you.
Again, thank you so Go much. For it.
Yeah. Let's dive in.
You gave John the hardest job.
Did I? I don't know. We've got some interesting questions.
I agree.
So, Dr. Harry, as a pediatric rheumatologist working on the front lines in Virginia, your perspective is just as vital. So can you please introduce yourself and help us understand this very troubling statistic? So you thought I gave him a tough one. I have a tough one too. So 67% of Virginia's 340B hospitals provide below average charity care, while at the same time generating over 3 times more profit from 340B savings than they reinvest in their communities. So what does that mean? What is happening behind the curtain?
Well, again, thank you. It's an honor to be here. And again, I'm Harry Gawanter. I'm a semi-retired pediatric rheumatologist, current president of the Virginia Society of Rheumatology, and I wear lots of other hats as well, but have been obsessed with drug pricing and how the money is not going to patients, and to those, since we're all patients, basically it's coming out of our pockets when we should not be paying so much. And it's actually not a surprise that 2/3 of the 340B hospitals provide below national average charity care, because when you look at all of Virginia's hospitals, they are below average in general. The charity cost of charity care is a share of operating expenses nationally is only a little over 2%, and for Virginia hospitals it's below 2%, 1.9%, and the ratios of what they provide for insured versus uninsured patients is way below as well. So what you need to understand about the 340B program, as it's been hijacked from its original intent, which was to provide low-cost medications to underserved and vulnerable patients, is it's turned into an arbitrage system where the contract entities, whether it's hospitals or contract pharmacies, can get a medication at a very low price. And unfortunately, there's a gap in the legislation that nobody is tracking who they sell it to and at what price they sell it at. So they can turn around and get medications at a very low price and then, sell it at list prices to insurers and make a ton of money in between. And what's turned out now is, as a result of all this, is these profits made off of the 340B program is now turned into really essential budget items, for the various contract entities. And we don't know what they're doing with the money. Clearly not providing charity, as much charity care as they're making from this, but there are so many problems with it because there are no limitations, for instance, on geography. So a hospital or contracting entity can set up contracts with other pharmacies throughout the country. And in fact, there are pharmacies in Hawaii and California that are contracted with Virginia hospitals and can turn around and buy, medicines low, sell them high. And so, when you look at it from a business standpoint, this makes perfect sense.
Right.
When you look at this from a policy standpoint, not so good.
Exactly. Yeah. Thank you for sharing that as well. So I think now we have a good understanding of the purpose of 340B. I think you've broken that down pretty well. And John, you talked a little bit about what MFN actually is. So how can programs like 340B and policies like MFN potentially work together to ensure Black communities in Virginia get greater access to affordable care and don't miss out on some of these medical innovations?
Yeah, thanks for that. Just to be clear, I don't think MFN can help anyone, any community
Wow.
in this country. MFN is good in concept, I think, but setting artificial prices by any method, whether it be internal boards to the states or whether it be by looking at other countries and saying, we're paying 100, they're paying 50, therefore we should pay 50, doesn't take into consideration what it takes to bring a drug to bear in America or for the world. We are the innovators of the world when it comes to biotechnology and drugs and therapies. And there's a system in place and how it works that shortcutting at the end by saying those prices need to be driven down artificially will cut off a supply of a drug and innovation. So I don't think MFN can help. 340B can, and I'm pretty sure Harry will agree if done right, with proper sunlight that's shown on the process and proper repercussions for those who abuse it, real repercussions. 340B is a great concept. It's a great theory when done right. So I encourage everyone to take all states, including Virginia, to take a look at the program and make sure it's executed right. That's all we want. From the perspective of the biotech industry and those companies that provide the medications for 340B, we have an incentive to want to see this done right. There's a reason why this industry provides drugs at a lower price, because we want to see people get their drugs at a lower price and also be supported by services that are enhanced and increased because of the program. When not done right, it totally eliminates the reason for the drugs to be provided a discount to begin with. So as long as everyone who says they're going to do this does it correctly, it can be done right and thus bring needed drugs at affordable prices to our communities, as well as needed services that are a result of the program. I fully believe that.
Absolutely. Dr. Harry, any thoughts?
Yeah, no, I think one of the things that is left out of all the discussion about MFN is that, as John started off, we have pharmacy benefit managers who take a list price and they negotiate discounts, supposedly, and then they set up formularies. And the formulary price, nobody knows except the PBM. And so that is a net price. all the discussions are about list prices, and the list price in the United States is essentially artificial. The
Mm,
list price in other countries is what the other country has negotiated. So essentially, these other countries that we're comparing prices with,
Right. It's apples
they
and
are PBMs, and so their list price is actually our net price, our hidden net price, because only the PBMs know that.
right.
So this is, in a sense, comparing apple-colored oranges to orange-colored apples. I mean, the words are the same, but the realities are not. And so
Yep.
there is, and from a physician standpoint, for example, for those of us who administer drugs, we're not going to be able to do it because the price is now going to get dropped to the point that we can't, afford to administer a drug, which means it's going to get done in hospitals or other higher cost settings. So it's not going to work. Um, and unfortunately, there are a lot of, as Neil deGrasse Tyson says, science doesn't care what you believe. And the data here is going to turn out that people who believe MFN is going to save money are going to discover that the facts don't bear it out.
absolutely. And so I guess now that we've shined some light on that, how can our community, our BDO community in Virginia, use their voices to make sure that programs like 340B or policies like MFN are shaped to expand access, to strengthen local clinics, and then return those resources back to the communities that they're supposed to go to?
Well, I think first of all, people need to find out, if their clinic or their hospital is using a 340B program and start asking questions you know, you know, these programs are set up for the contracting entities. They're not set up for patients to be able to get a 340B price.
Mhm.
The price is what is, but you can start asking all sorts of questions, to the entities. You can, when you're getting your own prescription, you can ask, are there lower cost items, or is this a 340B entity? And is it being processed under the 340B program? In which case, you could then say, also find out if there are other assistance or sliding scale programs, that would, are supposed to be covered under this, the 340B concept. But I think the biggest thing we're all talking about is transparency and accountability and consequences. So we don't know, for example, with any particular entity, whether or not a drug is going to the person who should be eligible for a 340B discount.
Mhm.
They're basically taking that money and using it for everybody. So I think people need to start sharing their stories with their legislators, who I prefer to call our hired help, to be able to really um, have the 340B program go back to its basics and make sure that the discounts are going to the appropriate folks for whom it was designed. But this is a political question in that sense.
Understood. And you talked about those people who are actually eligible for 340B. Who is eligible? Is everyone eligible? Is it only for certain communities? And then how do we make sure that those savings actually reach those who are eligible? How do we change what we've been discussing?
Well, I think part of it is with great difficulty because the law is unfortunately sufficiently vague and inadequately overseen, to be sure. CMS has recently come out with some reform concepts that they're thinking about putting into effect in the fall that actually a number of the companies have said, which is we want to make sure that the money that, the discounts we are giving to these entities is going to the right people. And at the moment, nobody knows. And so I think being able to, justify this is going to vulnerable populations, underserved populations, the federally qualified health centers, and are they using it for the patients who really need it and not everybody is a big deal. And so, we really need to you know, for starters, there's no standard patient definition, for who's eligible. So we need that. We need to have, one claim, one price rules, because what's been happening is some people have been double dipping on this. So there are so many administrative problems
Mhm.
with the way, great headline, devil's in the details, and the details have not been overseen, and there's not been, quite frankly, a federal priority
Mhm.
to do this. And part of the problem looking down the road is because these profits have been baked into the budgets of hospital systems. Um, they're going to have problems if you just do it all of a sudden. So whatever changes need to come are going to take, a transition period as well.
Mhm.
But it's stealing money from us, quite frankly. For instance, if you get a 340B discount in many states, you can't get a Medicaid rebate, and so that jacks up the prices for, both within the Medicaid system, but also for employers, because now they're paying inflated prices when the hospitals and other contracting entities should be charging less.
Absolutely. John, do you want to jump in here?
No, I really have nothing to add to what the doctor said. He is, we're so lucky to have him on this
Mhm.
program, given his perspective as a physician and his experience. So, really nothing more to add. So,
Sure. And Dr. Harry, you talked a little bit about those profits being baked into, I guess, their budgeting, the hospital's budgeting. So it sounds like the hospitals are the ones who are profiting when those savings don't make it to those eligible patients. Am I
Well,
correct?
they're not the only ones.
Okay.
What you also need to understand is that hospital systems can contract with somebody else or a qualifying entity. So even a federally qualified health center can contract with another pharmacy anywhere, and then everybody shares in the savings. So guess what? Walgreens and CVS, Caremark are two of the biggest pharmacy contractors with Virginia entities. And guess what? Not all of their pharmacies that are supposed to help serve underserved areas are in underserved areas. In fact, only 10% are in underserved areas, and a number of these are out of state, as well. So, it's the profits are being shared throughout the system with both the with folks who really don't need them,
Mhm.
and it's not going to the people who it was designed, all the people it was designed to serve.
yep.
Um,
So what would it take to build a system that makes sure that it gets to the people that it's supposed to get to, and then also holds people accountable, is transparent? What would it take to build a proper system?
a lot
I
of
know
work.
that's a question, yeah.
Um, no, but I think a couple things, I mean, just to start off, one, you need to have a standard definition, okay? You need to also be able to have some sort of tag on a claim so that people know it's going to the right person and it's not getting, double billed. You would need to have a model where things are clear and trackable, and to prevent duplicate discounts,
Mhm.
to make sure things are going to the right folks. You need some minimum standards, and you need some enforcement with teeth. So that would, for example, have to give the HRSA, John, you're going to have to help me with the Health Research Service Area, whatever HRSA stands for. But they would need to be able. We're supposed to be monitoring this.
Mhm.
They need to be able to have monetary penalties, and it's got to be fast, and it's got to really hurt to make sure people stay with it. And then we would need probably a 3 to 4 year transition period. But it's going to require a lot of political will, because you are going to have hospital and pharmacy benefit manager and insurer pushback, because this is going to require changes in their budgets. On the other hand, if you think about it, we're all patients, and we're paying for all of this one of three ways. Either we pay for it through our taxes, for public payers, we pay through it for our premiums, or we pay for it out of pocket. So basically, we're all paying, and it's just getting laundered through a system. And this is our money, and our federal government should be. You want to look for a place for waste, fraud, and abuse. 340B is the poster child.
Right. Absolutely. I'd love to know your thoughts on the Protect 340B Act. Do you think that is a good first step, maybe, in seeing these changes to 340B, or do you even think that Virginia lawmakers will support the bill? I'd love to know. John,
I'm going to pass that to John.
Yeah.
Yeah, and thank you. Virginia Bio, we are engaged in the government relations space, of course, state and federal. And this is a bill that I believe last was put forward in 2023 by then Virginia Representative Spanberger. And also it was bipartisan, Republican Dusty Johnson from South Dakota. I can't answer the direct question, which do I think Virginia lawmakers will support a bill like this? Because I personally have not spoken to any of our congressional delegation about their views on this. But I think the fact that it is a bipartisan bill that encourages and, quite frankly, would prohibit insurers and PBMs from discriminating against 340B providers by the nature of the 340B status, which does happen, unfortunately, and reduces those organizations' ability to use 340B. I think that concept, I would assume everyone would agree with. Granted, it's been sitting on the shelf since 2023, this bill, but all bills have been sitting on the shelf in Congress since that time, so don't take anything away from that. I think the concept is good, and this is something definitely in our next few visits to Capitol Hill, we definitely will speak to our own congressional delegation about.
Wonderful.
Yeah, I think there are really four things, and I'm not sure the bill's going to do it either, because it's not insufficiently specific. But if you look at the big things we want a bill that's going to protect patients, so that only the eligible prescriptions are going to apply, qualify. We want to restore trust in the system, and we need transparency so that the savings are used for patient care. First and foremost, that's the idea. We've got to reduce the profiteering. I mean, profits are fine. Everybody's got to make profits. Profiteering is not. And then we've got to preserve the safety nets, and so, again, this is something that the bill was originally designed to do, but it has gotten warped over time.
Absolutely. Well, I want to thank the two of you for sharing your insights. And as we come to a close, what is one message you would like our BDO community to remember? And if you had any advice for those who want to take action, what would it be?
Well, from my perspective, is remain educated and engaged on the issues. You are your best advocate at the end of the day. All of us are surrounding this community with information like this and trying to advocate at state and federal. But at the end of the day, it's really up to each of us to understand what's available, what our rights are, what resources are available. Can you benefit from 340B programs? All of that is really up to us. So don't sit back and be passive about it, be active.
Mm-hmm.
I would just say speak up, and if you want things to come out your way, you've got to be involved, and so sign up to be on boards of local hospitals or clinics or so on, to provide a patient voice and to ask these questions. Where's the money going? And push your legislators, push media to really look into this, because it's flown under the shadows for too long.
Absolutely. Well, again, I want to thank the two of you for joining us this afternoon. And thank you all for joining us for this important conversation. The road to equity in healthcare is not easy, but together we can demand greater transparency, accountability, and action that truly serves our community. So please stay connected with the Black Doctor Policy Hub as we continue to break down these complex policies and turn knowledge into power for change. Thank you all.
Thank you.